Please join me in extending a warm welcome to Dr. Mohan Kamath as we eagerly anticipate his enlightening insights.
Exactly.
Over to you, sir.
Yeah, I'll have the slides, please. Very good morning to all the senior faculty and delegates here. It's indeed an honor and privilege to be here giving this particular talk. I'm actually a little overwhelmed because I think I have a lot of senior faculty and teachers in front of me. So I'd like to thank Jai Krishnan sir and the whole team, and they allowed me to take the topic of my choice. So this talk is going to be a little controversial because I'm going to challenge the traditional dogma, and that's what I think I've been entrusted with. So the good part of this keynote address is questions are not going to be there, so I can get away with all this. So the topic is recurrent implantation failure, and I don't have any conflict of interest to declare. That's a very important point when you go for these talks. So the way I thought I will cover this is, actually I want to spend some time on the diagnosis itself, RIF, and then probably I want to work on this because that's very important for us to understand that if we can't identify an entity, clinical entity, then it's going to be very difficult to find out the solutions, okay? Because most of us are interested in the solution, but we can't really figure out what the problem is. Then we have a problem at hand. So then only, of course, I'm going to dwell through some of the possible solutions and possible take-home messages as well, based on evidence. So I always start with this: what is science? And I want to probably remind myself and everybody else, science is about what is already known. And it's not easy to figure out what is known, you know. And if we can't reproduce a result in science, then it's going to be a problem, you know. One group of people claim, huge claims are made for any intervention, and then another group is simply not able to replicate, then there's a problem, okay? And there's a problem of validity and so on. So I keep this at the background when we start this. So again, there'll be some, you know, slides on this problem called RIF, and we know that there is no clear definition for this. Over the years, there's been a huge number of definitions, and they have come down in the number of embryo transfers. In fact, there is a systematic review which actually quotes something like 15-20 studies with different definitions. So there lies the problem, that we don't know what to accept, and then it becomes very difficult for us to see what is working. So, and there is something that I want to point out, is that recurrent implantation failure is not the same as repeated IVF failures. This is a very fundamental difference that people are not taking cognizance of. So if you see any Cochrane review, it will not use the word RIF. It only uses the word 2 or more failures, because you can have a situation where we had a bad embryo transfer, we didn't do it properly, and you got no implantation a couple of times. We simply didn't have good embryos, so on and so forth. So recurrent implantation failure and 2 or more failures has to be segregated. Of course, ultimately at some point RIF will become an entity. Now, what is the work? So there are a lot of people across the world who are trying to zoom into when do you call a patient has got an RIF. So there are some plethora of publications, so I picked a few, but what we need to understand is they have used real-world data from SART and HEFA to come down to when do we call it RIF. So to us, the cumulative pregnancy rates are something like 60% after 3 cycles, and almost 80% of women should conceive after 6 cycles. Now what they have found out is actually that our false positive rate for diagnosing RIF is almost 75% after 3 cycles. What does that mean? If you take out the statistical jargons, is that 75% time we are actually overdiagnosing. This is after 3 failures, okay? So but finally with all the consensus in, they felt that 3 or more failures is a reasonable approach in clinical practice, but it still tends to overdiagnose. Overdiagnose, and the downstream effect is overtreatment. And that's what I'm trying to probably steer the audience away from, overtreatment. This group has actually published a lot, and they have finally said 3 IVF failures is what is working fine in clinical practice, but you still overdiagnose in 1 in 4 cases. Uh, of course, then things moved on, and people now have come out with a consensus statement. So there were a group of people sat together and went through all the data, and then they have come up with this particular approach, which I will delve on. This is that unreasonable to assign diagnosis until 3 euploid blastocysts have failed to implant. Okay, so this is the way they have said that is when you can actually start looking at an RIF diagnosis. True prevalence is actually as low as 5%. And this is something that is a take-home message, that true prevalence of RIF is very low. And when it is so low, most of the times just the conventional ART and reassurance is the way forward. This is a consensus statement published in FIRST in 2022 by a group of people working. But this is what those who are not doing PGT, there's an unscreened number of embryos equivalent. So you can see here that less than 35, 4 blastocysts unscreened, don't implant, then you can start looking at an RIF. But if the lady is between 37 or 35, it becomes 5. So 5 blastocyst embryos don't implant, then you would call it RIF. So numbers keeps on increasing. After that, of course, at 40, 41, it goes up to 7 to 13 and so on. So this is the working definition they have come up with. The crux of the whole particular issue is that we are overdiagnosing RIF big time, and that's the problem. Now, in real world, if I just try to simplify things, 2/3 times it's actually the embryo factor, 1/3 time it's the uterine factor. So essentially, because 65% is the implantation rate for euploid embryos, that's why the embryo factor is kept at a higher number. Now, we as clinicians would like to intervene a lot, and because that's a human tendency when things don't work, but we are only factoring and can modulate only the uterine factor. This is something that we need to remember, because embryos are 2/3 times the culprit. Now, what can happen? Why does things don't work? Why do the IVFs don't work many times? It's pretty simple if you really chisel it down. It's the embryo factor which is not working. Embryo factor works, but the uterine factor isn't favorable for that cycle, or both of them are not working. Now, it can very well happen that in the previous 2 cycles, the embryos were simply not euploid, and they didn't work. And the 3rd time, embryos were favorable, but we did a shoddy transfer or whatever happened at that point. So this combination can keep on repeating itself, but we will then start intervening at different levels. So remember that you might just correct one factor, and the other factor just simply goes out of favor. So this is the challenge as clinicians we would face all the time. Now, that's one thing at the background. You got a problem with the definition, overdiagnosis, and what we can do. There is something that I want to delve before I go in and start looking at the studies. There is something called performance bias. This is a statistical term, but what it means is when you are looking at trials, if, it is, what happens is whenever we are allocating one interventional arm and one control arm, whenever the people know that this group of patients have received the intervention, be it the GCSF or be it the scratch or hysteroscopy, you tend to do extra, okay, because you are aware of their allotment. This is called performance bias. This happens typically with humans, like any investigator will do this. The way forward is we actually have to have blinded trials. This is problematic in open label trials. Open label trial typically means that there is no blinding. And why I'm sharing this particular thought is because I happen to have been on the reviews for GCSF, endometrial scratch, hysteroscopy, and 1 or 2 more of them. And invariably, all these reviews have shown that there might be probably a better results with these intervention in RIF group. Now, why that is happening is because of one of the reasons is this performance bias. So it's very important for us to analyze the results of reviews and data and be aware of these methodological issues that might come into a trial. So my take is the performance bias is a huge factor, especially when we are intervening with so many newer things, that we want these things to work. It's a very innate human thing, and then it shows in the results. You want to measure the endometrium, this lady has got some intervention, you are going to be a little more generous when you measure. I really can't figure out 6.5 and 7. How do you actually differentiate, in millimeters? It's a very problematic thing at a methodological level. I also want to highlight that whatever gets published is not exactly the gospel's truth. If I would say that the youngsters should actually go and start watching a site called Retraction Watch. We as clinical researchers are watching, and there's so many trials are getting retracted day in and day out. In fact, I am quite aware of some of the recent guidelines have had a lot of trials which have had a retraction. So that is a big disservice to humankind, and that's what is happening at the background. So I thought I will share my thoughts because this is a big thing. So a lot of us have used hydroxyethyl starch for OHSs, I believe. It's one of those checklist things that what all have you given. We ask this in our DM and MD exam also. What do you give for OHSs? And people rattle out albumin and hydroxyethyl starch and so on. So this is a JAMA paper which was actually in a different setting, but I thought it's relevant because of the larger issue that I'm trying to address here. HES in critically ill patients. So I looked at this in the morning. So to just cut it short, essentially hydroxyethyl starch was not having any issues with the death rate in these patients, okay? But in this systematic review, when they finally took out those trials which had actually problems, and they were very problematic trials, 7 trials were problematic, identified because of various retraction. Actually, those trials were retracted, okay? But they were featuring in the original pool review. But when they actually retracted and recalculated the results, there was a higher mortality with HES, okay? So essentially, this is a JAMA paper, worth looking at it. Hydroxyethyl starch was actually causing more mortality than albumin and other things. So this is where this slide I put in just to highlight that how poor quality trials are affecting womankind and humankind. And I want people to understand that unless we understand this whole process, it's going to become increasingly difficult to decipher the evidence the way it is coming, because there's just too many publications happening. I just thought I will put in our specialty also. A lot of trials are being quoted. In fact, you would find one of these trials in the PCOS guideline also. But I can assure you that there are so many retractions in this PCOS and clomiphene and letrozole that you will be shocked. I didn't want to highlight who's and which group and all, but it's all there in the public domain, so I don't have to go into it. But this is the backdrop I thought I will pull in before I start going to the actual studies and maybe just skim through it, because I don't think I'll have enough time. So with this backdrop, I thought I will just look at what are the current updates for very commonly used interventions. Endometrial scratch is my favorite because I've been following this from times immemorial, and I like to see how the evidence have evolved in this. So this was a famous Barad study and Gleicher study which claimed to have 50% increase in live birth rate. So again, it started with the same thing, 17, 15 women, they found fantastic pregnancy rates and so on. But things never worked. There were few trials, so there is something called publication bias, where you have a lot of trials coming in positive, they get published, and negative trials don't get published. Eventually, negative trials start getting published. So this happened between 2010 and 15. So this trial is a negative trial. In fact, we ourselves had a negative trial which was published in 2017. 2015, there was a Cochrane, which was very controversial, which supported endometrial scratch, but then they realized the problematic trials. Till that review, world over, Cochrane felt that all trials are fair, okay, and they are done with lot of integrity. After this particular review in 2015 on endometrial scratch, there was a rethink. They felt that no, we will think it the other way around. Unless it's a high quality trial, we will not pool those results from poor quality trial. And that's why there is a fundamental difference between the Cochrane of endometrial scratch in 2015 and this particular update. So this particular update did not pool the results for 2 or more failures because they felt there were not enough trials for that. So this is the change that is happening at the background in terms of evidence synthesis. Of course, there was a famous scratch trial which did not find any difference in live birth rate in the 2 or more failures group. They didn't find anyways across the general population also. That was a PIP trial, sorry, and this was a scratch trial. Scratch trial had some effect. It included only only one failure, not two or more failures. They felt that it's a very problematic one. It's got 23% 19, and it was not significant, but there was some benefit is what finally it came out. So finally, this got published. We were there. Out of the 54 trials across on endometrial scratch, 13 were in. In that, 2 trials from India were there. One of our studies were there, and one was from Bangalore. And we were a part of this IPD meta-analysis, which suggested may improve results in endometrial scratch. But they found out that it doesn't get linked to 2 or more failures or number of, age of the lady and so on. So essentially, this also does not support scratch in RIF. So for me, the endometrial scratch journey is like this. It started like that, then it came to null hypothesis, that is, it's not working. Then it again goes, a pendulum swings other way, again it comes back and so on. So I think the jury is still out on endometrial scratch, but it's a good prototype of how evidence swings either ways depending upon the trials and studies that we have. But our ability to see through all this is very important, and that's what I tell my students, that if you can't really dissect these articles, we are now at the risk of being ignorant. So the same thing goes for hysteroscopy. Understand the terms. Screening hysteroscopy is very important for only, it is basically putting out that your ultrasound is normal and you still go and do a hysteroscopy, whereas operative hysteroscopy is when you identify a problem and then go in. Now, these two definitions depends upon the operator's ability to actually identify intracavitary lesions. So if operator is really good, they can pick up those polyps or adhesions and so on, and the current ultrasound machines are going to make it that more easier. So then the role of hysteroscopy is going to diminish. If you have a unit where people are missing out right and left intracavitary lesions, obviously operative hysteroscopy is going to work wonders there. So in fact, there are no trials on this, but I think I'll just go back to that. I slipped around. But there are some observational studies where if you have found a hysteroscope, a polyp or any pathology inside before IF, you definitely need to clear that. That's the operative hysteroscopy. But there is, in the screening hysteroscopy, there is no clear evidence. This is a very interesting table which we use. So this is 2 or more failure, our RAF. This is what we are interested in is. And again, as I said, the Cochrane did say that pooled live birth increases, but the evidence from high quality trials did not show any benefit. And the high quality trial there was the trophy trial. So you can see that in patients who had 2 or more failures, you can see the live birth, 29 versus 29. There is absolutely no change whatsoever. Okay, so I can just move on, but I'll just skim through some of the other interventions. Hydrosalpinx is one area where it is very clear that if you find a ultrasound detected hydrosalpinx, it needs to be, it can be, you can offer it to the lady, but remember that you have to take the risk-benefit ratio. If somebody has got couple of, big, large incisions, and then you want to go and do a salpingectomy, it's going to be very tricky. So risk-benefit ratio has to be considered. Evidence is there, but whether you want to offer it to all the ladies with attendant surgical risk is something that you need to consider. I will go to straight away GCSF, which of course we did the review. There was again, as I said, low quality evidence showing improvement, but as I said, it's low quality. We don't go by it because the trials are very few. ERA, of course, is the controversial intervention, and I'll take you through it. It's not exactly a patient-friendly. If you ask me as a clinician, I find it quite an unfriendly procedure because you are going to delay, you are going to commit for a freezing, and for us, we are in a tertiary center where patients come from very far away. So it's going to be a nightmare, logistical nightmare, as far as I'm concerned, when I look from the patient point of view. Now, I'm going to look at the evidence only in RIF, if at all, if it's available, but I'll also, Carlos Simon, the famous, group, actually came up with a very controversial randomized trial, which didn't get published in HR and Ferdstud, but finally made it into RBM Online with all the problems that it had. They claim that the live birth rates were actually not significantly different. They did not include RIF. Okay, so let's be very clear. Uh, but they claim that cumulative live birth was higher in ERA. But there were a lot of people waiting for this kind of trial to come out, and these groups went hammer and tongs after this trial. And they raised a lot of issues, methodological, and I can see why they have said that. Uh, there is a huge dropout before the trial started, 50%. And the conclusions by rule are supposed to be on something called intention to treat, whereas these people did something called post hoc analysis just to show some favor, and obviously the pressure was quite high. I can imagine what would have happened for that. So, of course, the pursuance for truth continues. So there is a big group from US which actually went on, and it got published in JAMA. So JAMA is supposed to be the top medical journal, apart from Lancet and NEJM. So this group actually went through a very interesting design. Again, no RIF, but then they had a single euploid blastocyst. They looked at ERA versus FET, and they did ERA on both sides, okay? But then, what they did, they didn't use the information of ERA on one side, they only used it on the other side. They found almost 55% patients were non-receptive by the ERA platform, and it was probably distributed equally. What they found was the live birth rate actually was similar in both the groups. So they went ahead, used the conventional way of planning FET and compared it with ERA. You can see the results. But more worryingly, they did something called post hoc analysis. And post hoc analysis showed that wherever they used the ERA and postponed the transfer by 24 hours or more, the pregnancy losses were higher. So this actually set out, it was quite a problematic reason. In fact, so we had to ask ourselves, are we harming the patient by offering this? So now the logic for using ERA is that it is believed that ERA might probably be more useful in RIF because it might have more displacement of the window of implantation. So that should actually work better. But for some reason, people are not using RIF as a population to test. They are using everybody else. And this is the classic problem with PGT, and it's a classic problem with RIF. Where we are supposed to be using it, we don't want to launch a trial. That is something that surprises me. So I looked at what do you call non-receptive endometrium? When do you call it? So in fact, madam's study is there. 27% in the Indian study, but Doyle study, non-receptives, 55. They had first IVF. Patel, there's one more study. Then there's a mixed study from Carlos Simon. So you can see that the so-called non-receptive endometrium is quite varying in prevalence. The problem also becomes worse because there are now currently, this is a reflection we had written in FERTSTUT on timing, and what we dug out was actually there are 5 different platforms being used to identify, and they're using anywhere between 11 to 238 genes to find out what is non-receptive. Now, which one of them is better? We really don't have an idea on this. So, in fact, the group which launched ERA, I think Antonio Pellicer was there. FERTSTUT, he is a EIC, editor-in-chief at some point. They, in fact, went on and started publishing the reverse, that actually it's not working. So this is their retrospective studies which showed that, in fact, live birth rates were lower, especially in previously failed IVF. So I would probably give kudos to these people because they had the daring to come out and tell in the scientific community, listen, these things are not working. These are the people who are originally involved in the development of that thing. So, in fact, they had 2 publications. I dug this out, and in both, ERA was actually not working. In fact, in one, it was doing more damage. So, this is an eye-opener. I really liked reading the discussion of these articles because they have really been very honest and transparent, and that's something that is not so easy. I will quickly rush through now because I have just 5 more minutes. Evidence overall, I think a lot of societies have clearly showed. In fact, I tried to look at what are the ongoing trials. In fact, none of the trials are ongoing on RIF. So you can't see the end of the tunnel anymore because, in fact, the trials have been stopped which were having RIF. So that's where it is. To me, it may actually cause harm. increased cost and patient burden, and the control for these trials, if any, should be modified natural cycle, no more HRT cycles. So PGT, of course, has similar issues. The famous STAR trial, I will not go into depth, but remember that the right way of interpreting the results of STAR trial are there no difference in ongoing pregnancy rate, either in the general population or 35 to 40. But they went on and tried to do something called fishing expedition, where you keep on hunting till you get a significant result. And they found it in a small subgroup of patients, but it doesn't cut ice in scientific community if you really get onto these kind of things. So essentially, this is, I don't know how this journal actually allowed them to base their conclusion on a post hoc analysis, which is something I would not agree if I'm the editor. Now, of course, the truth cannot be hidden. So there was a large trial after this, which is published in NEJM, which is one of the topmost in medical field, and it was a non-inferiority trial, essentially saying PGT would give better results, but we will rely and we will see if the conventional morphology would still hold true. And they had the fantastic cumulative live birth as an outcome. What they found was 80% of the ladies had live birth rate in the conventional arm, whereas the PGT arm had a cumulative live birth of 77%, which was statistically significant. And that was a big worry. Actually, they had a 5% loss of cumulative live birth, and what they said was that this was lost because mosaic embryos were not transferred, and they also had an issue about, they really found out that leading, you always have to understand nature can do wonders. There is a phenomenon of self-correction, but we believe that after 5th day, nothing is going to happen. That's the erroneous way of looking at science, because there are enough healthy live births after transferring mosaic embryos, and that was understood after letter to editor to NEJM. So this is where it is that we actually are harming sometimes by operating on PGT, because I can tell you that embryologists will know that if they are doing biopsy, it is going to have a cost. It also depends upon which stage of blastocyst they are doing it. There can be technical issues. You and me would know on that. Finally, some solutions I have just proposing. Probably one thing is things are not working. Please go back and check the consistency in terms of your stimulation, whether if you're using urinary, probably it's very important to understand whether batch-to-batch consistency is there. Elevated progesterone, that is something that is associated with lower implantation rates. I usually keep a very meticulous records of how the endometrium was, whether it's a triple line, just to be sure that we are not missing anything, because triple line, whatever said and done, gives you a good idea about presence of polyp or any other intracavity lesion. If you are seeing occult hydrosalpinx, that is, they appear during stimulation and go off, then you should probably chase them as well. Because sometimes those hydrosalpinx are more visible during stimulation. I, of course, will have to liaise with the lab and see whether the issues with sperm or quality, which oocytes, which usually is something that has to be discussed. And also how the other cohorts performed. If it is coming from, patient had a failure and that whole cohort didn't do well, then we need to know that it is somewhere else. The problem is not with the patient, it's somewhere else in the lab or somewhere we've had a bad run. And that happens quite often in practice. You have a cohort of patients who had a very bad outcome. And this is something as IVF specialists we live with every day. You are as good as your last previous cycle batch. That's how my sir had taught me. So I also look at very carefully the embryo transfer notes. If you had some difficulty, please be honest and be sure that you make a plan next time if you've had a problem. This is one thing that is nowhere in the baseline. None of your RIF definitions will capture the difficulty of embryo transfer. And we know that we are fallible. We can get into trouble however experienced we might be. So one of the strategies now, more and more, all of us probably are looking at is the oocyte number. Shesh study came up at 15, but then there was a study from Brachypolis which said that higher the oocyte yield, more the blastocyst yield, and that would lead to higher cumulative live birth. So essentially moving towards more aggressive stimulation, but not at a risk of patient safety. So we be very careful that you don't land up with OHSs and so on, but we have safer protocols. We can get away with agonist trigger and so on. So one of the ways forward is higher oocyte yield, Blastocyst or cleavage, I'm not stuck up on blastocyst because there are reasons. Sometimes you simply can't treat blastocyst. And the standard of care should be modified natural cycle or electrostimulated for an annularity. That's the way forward. This is the thing. And this is the final slide where we are just, this is the HRA RIF recommendation. And I'm sorry, it's very badly colored. You can't really figure out, but it's open access. You can see it. Just type RIF consensus and HR open and it will come. But what the point is that there's hardly anything there in recommended. Everything is in red. And there's a reason for that. You know, there is nothing. All they have suggested is please, first of all, stop over-diagnosing and over-treating. Just be patient, and counseling is the most important point that I would highlight. In RIF, we have a tendency to over-diagnose. Very few supported evidence-based measures. Most of them are unproven. And be very careful of introducing surgical or laboratorial interventions in RIF, because especially laboratorial, because you will create a problem for the generations to come. Minimize the cost and patient inconvenience, and automatically patient is going to stick around with you more than intervening with so many plethora of unproven things, and then you find a failure, which was bound to, and then you're going to have trouble counseling. So for me, it's a counseling, honest discussion about future IVF success and perseverance that usually works. Reproductive medicine, still more than an art than science. This is one of the cited, highly cited papers from our group, and there's a reason for that. Thank you.